everybody, today we're going to be starting our first lecture of the semester, and we're going to be talking about looking at abnormality, which is chapter 1. So in this chapter we're going to begin by defining abnormality, look at the historical perspectives of abnormality, look at some of the emergence of the modern perspectives and what we consider abnormality today, and then talk a little bit about modern mental health care. So what are we doing today? So there are different models of abnormality. So when you think of abnormal psychology, what initially comes to mind? What do you think of when you think of something that is abnormal? And generally we think of something that is not normal. But what does that mean exactly? So we know that in a sense that our problems in thoughts, feelings, and behavior can vary from normal to abnormal. But what does that mean exactly? Like if we think about obsessive compulsive disorder, or for people who don't like germs. I don't think many of us like germs, or we don't like to have our hands covered in feces. Many of us sanitize, probably some of us excessively. But does that mean that that's abnormal behavior? So at what point does this become a psychological disorder and it's not just a behavior anymore? We all feel down and depressed sometimes. At what point is this kind of not a normal reaction to something, and at what point does it become normal? So really what the problem is there's no clear dividing line that exists between normal variations in thoughts, emotions, and behaviors and what would be labeled as abnormal. So, it's not like there's this fine line that something is normal and something is abnormal. This is something that we, as a society, decide. And so the judgment on where to draw the line between normality and abnormality is relatively subjective. And so these are people deciding for us what is normal and what is abnormal. And those of you who come from different cultures, different backgrounds, may have different beliefs, practices that you do that are culturally appropriate, but if here in America people saw you doing them, they would think they're abnormal, but within the context of your culture or your social group, that would be considered to be normal. So psychopathology is the study of abnormal psychology that includes people who suffer unusual mental pain, emotional pain, physical pain. So psychopathology is another way of describing abnormal psychology, and that's what we study when we study the mental disorders, and that's what we're going to be focusing on in this course. So mental illness, common beliefs are that behaviors, thoughts, or feelings can be viewed as pathological or abnormal. And we're going to be talking a little bit in the next few lectures about the DSM, which is the Diagnostic and Statistical Manual. And this is the manual that we use to diagnose mental disorders, and this manual, for all intents and purposes, is kind of like the Bible of mental health, and it decides in our society what is abnormal and what is not normal. Collections of problems according to the modern view in thinking of cognition, emotional responding irregulation, social behavior are also seen as part of mental illness. So using the cultural norms theory, we can define abnormality by the culture and what culture defines it as normal or acceptable. So even if you think about American society, if you think about, let's look at just dressing. If you look at dressing at the turn of the 19th century, women were much more conservative. If you've ever seen those pictures of people who, in bathing suits, for example, like women wore full dresses for bathing suits, men wore long sleeves and shorts, and so if they ever came to a beach today and they saw women in those skimpy little bikinis, they would think that that would be abnormal, versus if we saw people coming to the beach dressed like they used to at the turn of the century, we would consider them abnormal. So even within our American society, our culture decides what is normal and what is abnormal. Also regionally, people in the South have different ways of behaving than people in the North, and so what might be acceptable in the North might not be so acceptable in the South. For example, I know a lot of people who come to New York City and think that the frenetic lifestyle that we lead and the long hours that we work is very abnormal, where they work kind of more 9 to 5, live very close to where they work, etc. So, but then if you're also thinking cross-culturally, so again, those of you who come from different backgrounds or who know people who come from different backgrounds, there are things that may vary cross-culturally that may be considered to be abnormal. Like, for example, in the Haitian culture, things like practices such as voodoo, for example, would be considered to be normal, versus in our society, in American society, we would not view that to be normal. There are also gender role expectations. So, boys that play with dolls are considered to be abnormal because that's not gender appropriate, although we know that's not abnormal. So cultural relativism means that there are no universal standards or rules for labeling behavior as abnormal, but it really is dependent on the culture and how the culture views it. So we very much have to, that's one view, is the cultural norm view. Culture and gender can influence the way people express symptoms of abnormality. For example, women have a tendency to seek support more often than men. So women are more likely to go and seek therapy, to talk to other people about it, whereas men have a tendency to more to internalize their feelings, and so psychopathology can be viewed differently for women and for men. People's willingness to admit certain types of behaviors or feelings. For example, those who belong to the Asian culture, oftentimes it's not deemed appropriate to talk about, feeling down or sad, and so we see a lot of somatization, which is the bodily manifestation of psychological symptoms. So a lot of presentation of pain problems and problems sleeping, problems eating, versus kind of more, I'm feeling sad, I'm feeling depressed, that kind of thing. And then types of treatments deemed acceptable or helpful for people exhibiting abnormal behavior. So, I think for the most part in American culture or Western culture, it's acceptable to go and seek help in psychotherapy and to take medications for problems. But in some cultures, it's considered very inappropriate to go outside of the family unit to seek help. So one of the things that we see is that the prevalence of schizophrenia, which is generally a biologically based disorder, is higher in Western countries than it is in non-Western countries. However, what we find is that in non-Western countries, it's not that schizophrenia is expressed less frequently, it's that those individuals, they don't seek help for their loved ones, but rather take care of them within the family. And so that person is just viewed as kind of like crazy Uncle Felix, rather than somebody who has a mental illness. And so that person is just part of the family and is taken care of by the family. So the 4 Ds of abnormality, and this is kind of something that you need to know that's important, are dysfunction, whether it interferes with a person's ability to function in everyday life. So a lot of us have, as I mentioned, cleaning phobias, etc., germ phobias. But when it gets to the point where you can't leave your house, where you can't hold a job, where you can't, engage in a relationship anymore because you're so afraid of touching somebody and getting germs, or leaving the house and getting germs, that's when it becomes a problem and you're suffering from a dysfunction. Distress, that it causes emotional or physical pain. So using the same example with the germs, if it causes so much distress that you cannot, stand it anymore. Like I've seen people who, want to kill themselves because they can't deal with the emotions that they feel. They get overwhelmed by the feeling they can't handle the germs anymore. Deviance, that leads to judgments of abnormality, so that we view the behavior as being deviant. And dangerous, that the behaviors and feelings are potentially harmful to themselves or somebody else. So those are the 4 Ds of abnormality. So know those: dysfunction, distress, deviance, and dangerousness. If you have the 4 Ds, then the behavior or feelings could be classified as maladaptive or abnormal. So let's talk a little bit about the history and historical perspectives of abnormality. So there are biological theories where abnormal behavior is similar to physical diseases and caused by the breakdown of systems in the body. And you'll see as we talk about various disorders this semester that there are some disorders that are more biologically based than others. There are supernatural theories that abnormal behavior is a result of divine intervention, curses, demonic possession, and personal sin. While we've kind of moved away from this in today's society, there are still people who believe that to a certain degree. And there are psychological theories that abnormal behavior is a result of trauma or chronic stress. What I believe is really a biopsychosocial theory, which means that people have a biological vulnerability to have a certain psychological disorder, but then in conjunction with environmental factors and psychological and social stresses, this exacerbates the underlying biological vulnerability and leads to mental illness. So some of the ancient theories, in prehistoric times, they really believed strongly that mental illness was demonic possession, and so they conducted exorcisms, and they actually performed something called trephination. So that's like your spelling bee word for the week, where they actually cut sections of the skull out and made holes that allowed the evil spirits to get out of the person's body. The person probably then would eventually bleed to death, and if they didn't drill the hole properly, they could also damage the brain. And so they would then believe that this was a result of the spirit, that it caused the person to die. In ancient China, they talked about balancing the yin and the yang. You've probably seen those diagrams where you have the yin and the yang, the black and the white, and that everybody has part of that, and that mental disease, results when those two halves are not properly balanced. And so you would control those by making sure that your internal organs were well controlled. And then in ancient Egypt, Greece, and Rome, there were more biologically based theories, and that the hysteria, which we now call kind of anxiety, was biologically based, and they resulted in the balances of the body's essential humors, so, your blood and all those things. In the medieval times, abnormal behavior was attributed to physical causes or traumas, and there was a lot of by some belief in witchcraft, and that witches caused mental illness. And some people think that the people accused of witchcraft were possibly those who actually were mentally ill, and they had some sort of psychotic behavior that was interpreted then as being them being witches. So they actually had what was called psychic epidemics, where large numbers of people engaged in unusual behaviors that appear to have a psychological origin. It's not clear exactly what that was, because people just wrote about it or you hear about them. We know there are things such as folie à deux, where people who have very strong, who live together, sometimes if one person becomes psychotic, the other person can also take on their symptoms. So it's not clear if it was some sort of contagion, or people were being kind of led astray by somebody, but we saw things like that. So then in the 18th and 19th centuries, we started talking about the moral treatment of those with mental illness, and there was what's called the mental hygiene movement. And so while previously people might have been incarcerated with mental illness or persecuted or even stoned if they were thought to be witches, we started to have a more humane way of treating the mentally ill. And they started to believe that people became mad or mentally ill because they were separated from nature, and that more people, when there were rapid changes in the culture, became mentally ill, which is actually quite reasonable. And we see today, when we have rises and falls in the economy, mental illness gets exacerbated, in times of economic stress, in times of, around 9/11, when there were political stresses, etc., we see more mental illness coming about. So patients would be provided with humane treatments to live in because up until then, they were often locked away in these basically prisons and dungeons, and they didn't have human contact. And so a lot of patients were not benefiting from the treatment that we were supposed to give them. Then looking at it from a biological perspective, Wilhelm Geisinger was one of the first to kind of talk about psychological disorders being explained in terms of brain pathology. And we'll talk about this a little bit later in the semester. But there are different structures in the brain that can cause different types of pathologies. Kraepelin, who's another German, was one of the first to develop a scheme for classifying symptoms into discrete disorders, some of that which is followed even today. So if you've ever heard of the term dementia praecox, which was the first term for kind of psychotic disorders, so he basically separated disorders into depression and dementia praecox, which was psychosis. He also worked closely with Alzheimer, who was the first individual to talk about dementia, and so he was really very much involved in what is known today as our classification system. So there was then the discovery of the cause of general paresis. So it's a disease that leads to the paralysis, insanity, and even death. And so this was a disorder that was biologically based, and that kind of similar to syphilis, which could then eat away at the brain, and then which eventually would kill the individual. Excuse me. So then moving towards a psychoanalytic perspective, which is most strongly associated with Sigmund Freud, we had mesmerism, which was developed by Franz Mesmer, who was also a German, and he believed that animal magnetism was used to cure disease because there was a dysfunction in the magnetism in a person's body. When he talks about animal magnetism, he talks about basically force fields in the human body, and that between us we each have our own force field, and that people who were able to cure others had very strong animal magnetism. And so he was actually kind of kicked out of Vienna because people kind of thought him to be a crock, and he went to France, and half the people there believed him and half of them thought he was not very well established. And so, but he had a very large patient practice, and he would see patients and he would use his hands to work on the body's energy, kind of somewhat similar to what Reiki is today. And then in the late 1800s, you had the emergence of psychoanalysis, again, which was coming out of Vienna, where Freud started to study the unconscious, and that he believed that psychopathology resulted when there was a conflict between the id and the superego, and the id was the unconscious, and the superego was kind of the conscience, and we'll talk about that a little bit more. We also saw the emergence of other modern perspectives, such as behaviorism, which was the Wundt and Watson and B.F. Skinner, and they talk about classical conditioning, so where we're conditioning responses to the presence of stimuli, and behaviorism, where we look at the role of reinforcement and punishment in determining behavior. So those of you who have children or who care for children who have younger siblings, you know the power of reinforcing positive behaviors and ignoring negative behaviors, and how that can influence child's behavior. We then have the cognitive approaches, where we have cognitions that are thought processes that influence behavior and emotion. So it's our internal dialogue that we have with ourselves and how we think about things. And then self-efficacy beliefs. And so you'll see that a lot, that people's belief in what they can do can very much influence their outcomes. There's also a movement kind of in the 50s and 60s to deinstitutionalize mentally ill patients. And I think the initial goal was a good one. I mean, we had a lot of people, if you ever think of the movie Girl Interrupted, you saw in that time a lot of people who had very mild cases of depression, anxiety, etc. were now being housed in institutions. And that wasn't necessarily ideal, and it cost the state a lot of money. But I think we went the opposite way in terms of institutionalization, whereby we're no longer even, we have so few hospital beds now available to us, and this is largely budgetary, that we have people who do need hospital care who aren't able to receive it. But basically the goal of deinstitutionalization was integrating mental patients into the community with supportive community-based treatment facilities, which is all very well and good, except that currently we don't have adequate community-based treatment facilities to treat all the people with mental illness. And patients also had their own rights movement, whereby they wanted to recover and live more satisfying lives, and they felt that that would be better accomplished living in the community, which I completely agree with and the research supports. However, there have to be adequate resources in the community. And so we need to, the community mental health movement was to provide coordinated mental health services to people in the community via community mental health centers. Again, a great idea, still not the best implemented. So if you look at this is the trend in number of psychiatric beds in Western Europe. Across the board, we are seeing huge cuts from the 1980s to the year 2000. And the same, graph would apply to Western, to American and Canadian hospitals as well. Community mental health centers there are halfway houses. So these people who have long-term mental health problems, it gives them the opportunity to live in a structured, supportive environment. This doesn't mean they have to have a criminal conviction, but it's kind of more like a residential facility where they have the ability to come and go more or less as they please in a supervised, structured environment. There are day treatment centers where people can go and receive treatment during the day, as well as occupational rehabilitative therapies, and can do work training, etc. there. So people live at home at night and go to the treatment centers during the day. Managed care was a collection of methods for coordinating care for people who need services, and it ranges from simple monitoring to total control. My apologies. So it ranges from simple monitoring to total control over what care can be provided and paid for. So here, this is unfortunately where money kind of comes to play. And so we want people to have as many services as they want or as they need, but that's not always available to them based on the insurance that they have or the type of illness that they may have. So it solves some of the problems created by deinstitutionalization, but in my opinion, what I've seen in the in practice, it definitely leaves people lacking. What's really a good program that I've seen kind of work is called Assertive Community Treatment, or ACT. And Professor Janos here at John Jay does a lot of research with ACT treatment, and that's where you have service providers actually go out to people's apartments and work with them, and they belong to teams, and so it prevents people from falling through the cracks. So there are definitely programs that are helping out there that can be useful. So talking about professions within abnormal psychology, those of you who are thinking of pursuing psychology as a profession, they're psychiatrists, and these are medical doctors. They go to medical school and then do a residency in psychiatry. So this is a great deal of education, usually probably 10 years plus. And psychiatrists generally don't provide therapy, but they do provide medication. So this is especially important for those with psychotic-based disorders, but also people with depression and anxiety. Clinical psychologist, which is what I am, is that you receive a Ph.D. And you get accepted to a clinical psychology program. And after you get your Ph.D., so you do clinical work and research. I had to defend a doctoral dissertation. You have to do a pre-doctoral internship where you spend a year doing clinical work, and then you graduate. And then after that, you need to have at least 1 year postdoctoral clinical work. And then you get licensed, and you sit for an exam, and then you, depending on the state, have to do additional either testing or oral exams or whatever before you can be licensed. People who are marriage and family therapists generally have master's degrees, specifically in marriage and family counseling, and they work specifically on marriage and family counseling. They're clinical social workers, so you can do this with a bachelor's degree, but most of them are master's level social workers who then become licensed. They're also licensed mental health counselors, so certain states have mental health counselors who are generally licensed at the master's level. We have a forensic mental health counseling license eligible program here at John Jay, those of you who are interested at the master's level. There are psychiatric nurses, so these are nurses that receive an additional training with working with psychiatric patients, but they cannot prescribe. So currently, this figure shows the most common way that we think about understanding mental health today, and that's integrationist perspective. And so this is what I was kind of talking to you about, the biopsychosocial. So you have biological vulnerabilities, and then there are psychological factors and social factors that contribute to the development of the mental health problem. So having one of these alone oftentimes is not sufficient for somebody to become mentally ill, but in conjunction together they can work together to either cause the expression of the mental disorder, or when you're doing interventions, these are things that you can't really target biological factors, but you can work on social and psychological factors to decrease somebody's risk for experiencing mental disorder.